Hi everyone, welcome to Point of Care Nurse. My name is Gozi. Today we're talking about conduction abnormalities for the Ccrn exam. And I want to say one thing. So I think when I took the exam, I feel like I had a couple of strips to review or interpret during the exam. And there were questions about the effect of the rhythm on the body. I think it was blocks. I don't quite remember, but it's important to know your rhythms, recognize them, and certain ones you need to know their effect on the body. I think we spoke about a block when we did cardiac assessment earlier. If not, we'll talk about it as we go along. Okay, so today we're talking about Wolff Parkinson's White syndrome. So, Wolff Parkinson's White syndrome, we're going to say WPW, is a genetic condition, something that people are born with. So, in this case, they have an accessory pathway for electricity to travel from one portion of the heart to the other. So, usually, for the heart to beat, the SA node has to transmit signals to the atrium, get the atrium contracting, and then that signal travels down to the AV node. The AV node picks up the signal, delays it a little bit so that the ventricles can fill with blood, and then the AV node sends that signal down the Purkinje fibers, and then we have the ventricles contracting. In someone who has Wolff Parkinson White syndrome, they have another avenue where the electrical signal can travel from the atrium to the ventricle or the ventricle to the atrium. It presents differently in different people. The electrical signals can go either way from one chamber, from the top chamber to the bottom chamber, or the bottom chamber to the top chamber. It varies. But the bottom line is that we have an accessory signal running around and bypassing the main signal, the main electrical signal generators, which are the SA node, the AV node, and the Purkinje fibers. So this other pathway is just doing its own thing. And one trouble it can cause is tachycardia. So the patient can go into supraventricular tachycardia. So to recognize Wolff Parkinson's White syndrome, of course, an EKG is done. And on that EKG, there will be a delta wave. The delta wave occurs after the P wave. So you won't have like a normal looking EKG. When you have the time, if you don't know what it looks like, when you have the time, look up WPW strip. Even if you know what it looks like, just for a refresher, you might want to look it up in case you see it on the exam. You can recognize it right away, answer the question, and keep it moving. Okay, so an EKG needs to be done to diagnose this problem. Sometimes the patients might come in complaining of, my heart is racing, I'm having palpitations. I'm not having it right now, but I had it, a while ago. So it's kind of transient, the tachycardia. Okay, so another problem with Wolff Parkinson White is that it could present as pre-excited atrial fibrillation, right? Where we have a heart rate of 150 beats or greater that is irregular and has a wide QRS complex. Now, obviously, when a person is tachycardic and the heart is beating very fast, one symptom the person can have, or a couple of symptoms they can have, are dizziness, of course, palpitations, they feel like their heart is beating out of their chest pain if the heart is beating really fast and not getting enough time to be oxygenated with blood return, um, and perfusion, shortness of breath, and the person might pass out. So, this is something that needs to be treated if it gets symptomatic like this. So, treatment for, and this is very important for the CCRN exam, treatment for Wolff Parkinson's White includes ablation, which is, the patient goes to the EP lab, they find out where this reentrant, where the accessory pathway is or where they are, and they kind of destroy them where they are. So then the patient won't have Wolff Parkinson's White anymore. Now, if the patient is having a tachycardia, SVT, and it's unstable, the thing to do is to treat. we have to treat this patient. If the patient is unstable, it means their blood pressure is low, it means they're dizzy, they feel like passing out, or they're passing out in front of you, they're short of breath. In this case, you would do a synchronized cardioversion to hopefully get them back into a regular rhythm and get them out of the unstable, irregular rhythm. Another thing about SVT is that we give adenosine, right? When the patient is in SVT, we give an adenosine 6-12-12, and hopefully the tachycardia will resolve itself. Now, if the patient has pre-excited atrial fibrillation, we don't want to do anything to slow down the AV node. We don't want to do that. That means we don't want to give adenosine, which is kind of, you know, what we usually do when the patient has SVT. But if it's pre-excited atrial fibrillation, we don't give adenosine, we don't give digoxin, and we don't give any calcium channel blockers, because if you do, you slow down the AV node, and this rogue accessory pathway could take over the job of the AV node, and now you have the heart beating in a crazy fashion, in a crazy manner, right? So for the Ccrn exam, you have to remember that in the case of pre-excited atrial fibrillation, when we're talking about Wolff-Parkinson-White syndrome, we don't give adenosine, we don't give digoxin, and we don't give calcium channel blockers. If we do, like I said, this accessory pathway could take over, and we could have ventricular fibrillation as a result. Now, medications that we can give in pre-excited atrial fibrillation are amiodarone, procainamide, and beta blockers. Okay, now for the CCRN exam, it's important to know about long QT intervals to know the causes and the treatment, because you might have a question on that on the CCRN exam. So prolonged QT intervals can be caused by drugs or electrolyte imbalances. Drugs such as amiodarone, procainamide, haloperidol, we give Haldol quite a bit, and quinidine are some medications that can cause torsades de pointes, or I'm sorry, prolonged QT intervals. Electrolyte imbalances can also cause prolonged QT intervals. So when you have a situation like low potassium hypokalemia, low calcium hypocalcemia, low magnesium hypomagnesemia, these three things can cause prolonged QT intervals. Now the treatment for torsades is simple. Just magnesium, administer magnesium. That's the treatment for torsades de pointes. Next, we're going to talk about pacemaker therapy. Now I remember. Now I remember. During the exam, I had a question. It was about knowing if what the issue was with the patient's pacemaker from the strip. It was asking me if it was failure to capture, failure to pace, failure to this or that or the other thing. So this is something that is important for you to know. Okay, so when we talk about pacemaker therapy, basically the patient has an implanted cardioverter defibrillator in their chest to help. It paces the heart as well as defibrillate. So we need to know the pacemaker codes for this ICD that's implanted in the patient. So pacemaker codes could be A for atria, V for ventricle, or D for both, dual, which means the pacemaker is either pacing the atria, or is pacing the ventricle, or it could be pacing the two chambers. So you have different, you probably know this already. So when you say the patient has a VVI pacemaker. So then what's VVI, right? VVI, V for ventricle, V for ventricle, I for inhibit. So this is a pacemaker that the first letter is the chamber that is paced, V for ventricle. So this is a pacemaker that is pacing the ventricle. The second initial is what chamber is sensed by the pacemaker. So another V means the ventricle is also being sensed. So for VVI, the pacemaker is pacing the ventricle, it's sensing the ventricle, and then for I, it's then inhibiting. It's inhibiting the the ventricle. You could have a situation where you have the pacemaker pacing both and sensing both and inhibiting both chambers. Now, the pacemaker can malfunction, and you can tell it's malfunctioning from the EKG. I had a patient once with a pacemaker, and I kept looking at the cardiac monitor. It was weird. It wasn't really pacing. It wasn't doing anything. I couldn't see the spikes, nothing. And then the patient was also pretty cardiac. So luckily, I work in a hospital where we have resources. I said to the resident, I don't think this guy's pacemaker is working. Immediately, the EP fellow came over, interrogated the pacemaker, and said, like, yeah, there's something wrong with it. I think the battery was dead, something, something. So they had someone come in to take a look at it. But anyway, three basic malfunctions of the pacemaker are failure to pace. So it's not pacing, which means when you look at the EKG, you see no spikes, right? Failure to capture, which means you're seeing the spikes, but the heart is kind of not catching the spikes. So the heart is not responding to the pacing from the pacemaker. So you don't see a QRS complex. And then failure to sense. These are the three issues you can have with the pacemaker, and you can be quizzed on this by them giving you a rhythm, and then they ask you what's the problem here. Is it failure to pace? Is it failure to capture? What's going on? So it's important to know what it looks like on an EKG and what it actually means. Now, pacemakers can do different things. They can shock the patient when needed, meaning defibrillate the patient when needed. They can break up a tachycardic rhythm. So if the heart is beating fast, the pacemaker can go faster and try to trick the heart into, you know, resetting itself. So the pacemaker will go faster, pace the heart faster, 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 and then stop to see if the SA node will take over from regulating the heartbeat. And then, of course, the pacemaker, I keep saying pacemaker, I mean the ICD. It can shock, it can burst pace, which means it can break up a tachycardic rhythm, and it can also provide pacing for bradycardia. If the defibrillation doesn't restart the heart, you need to start CPR, and we need to shock the patient as usual. The only thing is that the pads shouldn't be placed directly over the ICD, should be placed away from it. And one thing about the ICD is that I've had patients that came in because their ICD was shocking them, and it was very unpleasant for the patient. So the patients need to be educated that this can actually happen, and if it happens, they need to contact their provider. So that will do it for this portion of the Ccrn review. I hope you found this useful. Please like, share, and subscribe, and I will see you in the next video. Take care.